Thank you for the invitation. I will be chairing the sessions after now. I will chair the first session with Professor Rupert. Professor Rupert Pierce was graduated in 1996 from St. George's Hospital Medical School, London, UK. After a time of working in general medicine and anesthesia, he returned to St. George Hospital, where he developed many of his current research interests and completed his training in intensive care medicine. In 2006, he was appointed senior lecturer in intensive care medicine in Queen Mary University of London and was promoted to professor in 2014. He has now given up anesthesia to concentrate more on the critical care. And he's now working on an adult critical care unit in the Royal London Hospital, and his research into improving patient outcomes following major surgeries. Robert has played a leading role in a number of large multi-center trials and has a growing interest in global health research, including as a chief investigator of a major global health trial of high versus low oxygen concentrations in major abdominal surgeries. I will now invite Professor Rupert to the stage. Professor Rupert, you have 30 minutes to present on what is global health, why is it important, and also what percentage of it is an acute care. And we have another 10 minutes of discussion. So for those of you who has questions, use the chat box to write your questions, or you can also direct your questions to Professor Rupert after the presentation directly. For those who are attending from the meeting hall, please forward your questions to the representative so you can get an organized question. For those of you who are attending individually, you can raise your hands on the view, so on your video, so we can pick the people who have raised their hands. Professor Rupert, you're welcome. The floor is yours. Professor Bruce Pickard is a speaker for what is global surgery on this stage. So he is a second chair in the Department of Anesthesia and Perioperative Medicine at Groote Schuur Hospital and the University of Cape Town, South Africa. His research interests include perioperative medicine, perioperative outcomes, and global surgery. He's a proponent of international collaborative research. He collaborates with the African Perioperative Research Group, APORG, where he has led the African surgical outcomes, like the ASOS 2 trials, and he has also co-lead the COVID-19 critical care research that we just did, the ACOS research. So Professor Bruce, welcome to the stage to speak on what is global surgery.
Thanks a lot. Thank you for this invitation this morning. Thank you to FITSIM and the N4PCc team, and to the WHO African region, and for the Ethiopian Ministry of Health. Thank you all for allowing us this opportunity. FITSIM has asked me to address the question of what is global surgery. And a lot of the talk I'm taking today is based on a lot of the educational work that the Global Surgery Division at the University of Cape Town, the educational component as a foundations course. So it's based loosely around that. For people interested in global surgery, there's the link to their educational activities, which I would strongly suggest you explore. So I'm going to chat about 5 things. What is global surgery and unmet need for surgery? A bit about the Lancet Commission on Global Surgery and Surgical Outcomes in Africa. Social determinants of health and health equity, the surgical pathway and bellwether procedures, and health system strengthening and quality of care measures. Just some disclosures on funding. So, as an introduction, we've been involved in ASOS, ASOS2, ACOS, and APORG, which is the network of clinical researchers across Africa. ASOS, we received a little bit of funding from MRC in South Africa, but essentially that study was done unfunded as we received the money after the study. ASOS2, we had a sub-grant from Bill and Melinda Gates, which essentially was about $1 per patient, and that was used to manage the database and the data administration for the study across Africa. Again, the database for ACOS was supported by the Critical Care Society of Southern Africa, and the Evidence-Based Perioperative Medicine Group raised funds for a database for APORG across Africa, and the beta version is running, and you'll hear a bit more about it tomorrow. So what is global surgery? So it's an area of study, research, and practice and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical, obstetric, and anesthesia care. And there's a special emphasis on underserved populations. If we look at health, about 1.3 billion people don't have access to the most basic healthcare. And if we look at surgery, the Commission suggested the following: there are about 5 billion people who lack access to safe and affordable surgery. We need about 143 million extra surgical procedures per year. And there are about 33 million people at risk of catastrophic financial burden. That's defined as more than 40% of your net income per annum. We need to think about health equity in global surgery because, you know, often people talk about improving longevity, falling maternal mortality, increasing childhood survival. But the reality is that's talking about equality. Equity is really thinking about patients having access to the same resources or resources needed to achieve similar health outcomes. And I think the work that we've all been doing in Africa demonstrates how little equity there is in health, and particularly in acute care in Africa. And this really is what we need to be focusing on. We need to focus on health equity for our patients. So there are a number of determinants of quality surgical care. So there's social determinants of health, and then I'm going to chat a bit about non-obedience principles of quality surgical care. So social determinants, these are the non-medical factors that influence health outcome. They've got to do with where we're born, where we grow up, where we work, live, and get old. And these are the sort of systems which shape our daily life, and they also affect our health. And there are a number of things which determine this, and it's economics and social norms and policies and politics, for example. If we look at non-obedience principles of quality of care, what we see here is that the structure of the care and the process of the care determines the outcomes for our patients. And so structure talks about resources, both physical and human. Processes are what happens around the care of the patient. And there are a lot of things that we can think about when we think about structure and processes, and they're all, you know, we can think about them as how do we use them for advocacy, how do we set up regulatory requirements to ensure healthcare is better, how do we finance the health, how do we track this quality of care, what education do we provide for our patients. For essential surgery, the Lancet Commission defined 3 bellwether procedures. This was the midline laparotomy, cesarean delivery, and the treatment of an open fracture. Now, they defined these as the requirements for a hospital to be able to deliver surgery. They should be able to provide these 3 surgical procedures. The DCP3, and that QR code is actually to the Essential Surgery DCP3 book, which you can readily download for free. It's excellent. They define 44 surgical procedures which they considered extremely cost effective. So, I mean, these are really the places we need to start. We need to ensure that our district general hospitals, which provide surgical provisions, can provide the 3 bellwether procedures. And the first 44 procedures we need to focus on are those listed in the DCP3 guidelines. The next thing is looking at access to surgery, ensuring that the patient gets to surgery quickly and that the health system is functional through the community to the primary healthcare center, to the first level of district hospital, and then to a higher level secondary and tertiary hospitals. So really, we need to capacitate the first level hospitals or district hospitals to be able to provide bellwether procedures. And we need to ensure that the patient pathway to that district hospital is clear and quick. So how do we improve global surgery? And this really is looking at how do we strengthen our healthcare systems and how do we determine a minimum level of quality of care. Healthcare system strengthening, I think we've had great work from the Lancet Commission on this. They set out these indicators, which are benchmarks for what we need to do. Access to timely essential surgery, and there's a definition for that. There's a definition for the specialist surgical workforce density that we need, the surgical volume that we should be trying to achieve annually, that we should be tracking perioperative mortality so that we know how we're performing, and finally protecting the patients against catastrophic expenditure for accessing surgical care. If we look at Africa in the light of this, of healthcare strengthening, these are the data from ASOS. What we see is we have less than 1 specialist per 100,000, a specialist being either an anesthetist, obstetrician, or surgeon. And the recommendation, based on data supporting increased survival for maternal mortality or for mothers at the cesarean delivery, is about 20 to 40. So that's the target. And how far are we off? It varies between about 20 and 50-fold less than the minimum requirement for safe surgery is the number of specialists we have. And you can see the surgical procedures are at the hospitals are tiny, and we should be targeting about 5,000 procedures per 100,000 patients, and we're way off that in Africa. So if we look at the surgical specialist workforce, surgical volume, and perioperative mortality, this is what we see. So the first thing we see is there's an inflection point for maternal survival with cesarean delivery, needing about 20 to 40 specialists per 100,000. And this is the data from ASOS, less than 1 specialist per 100,000. If we look at workforce density from anesthesia providers, we need about 4 providers per 100,000 to achieve that inflection point of safe cesarean deliveries. Africa runs at essentially less than 1 per 100,000 across the continent, and this is not necessarily physicians. These are all individuals providing anesthesia. So you can see we're way off the workforce density we need. If you look at surgical volume, so what we've done here is we've taken the data from the surgical outcome studies, ASOS, ISOS, USOS, and from the global surgery studies as well. And we've used that data to get an idea for volume of surgeries across countries. And if you look at the target of 5,000 per 100,000 as per the Lancet Commission, what you see is only once you're high income country do you achieve this objective. Most of Africa is low income and low middle income countries, and the volume of surgery that needs to be increased to achieve these objectives is huge. In the low income countries, we estimate that you need to do 25-fold more surgery to get to 5,000 cases per 100,000 population. These are the data just shown graphically for African countries from that data set on the volume of surgery per 100,000. On the right is the United Kingdom, as they actually do run almost at 5,000 cases per 100,000. But then for the rest of Africa is below. Botswana just over 3,000, and Namibia, South Africa at about 2,000, and then you can see it tails off very quickly, which is obviously extremely disturbing. What about surgical outcomes? So we talk about benchmarking and perioperative mortality. So what you can see in front of you here are surgical outcomes in global studies. So in Vision, the 30-day mortality, that's all surgeries in adults, runs at about 2%. If you look at ISOS elective surgery, in hospital mortality about 0.5%. If you look at children, APORG, a European study, 30-day in hospital mortality about 0.1%. And if you look at cesarean deliveries from the NESQIP data in the US, maternal mortality of 0.01%. So these are data from Africa and South Africa. Look at ASOS, all surgeries, 2% in hospital mortality, and elective surgery, 1% in hospital mortality. You look at SAPSOS, which was a South African pediatric surgical outcome study, in hospital mortality of 1%. The study, which is just starting now, ASOS Beads, is the consequence of SAPSOS. SAPSOS was what we would call a pilot. We had about 60 hospitals in South Africa, and through the findings of SAPSOS and refining the data set, now we're running the ASOS Beads project across Africa. And then finally, the cesarean mortality in Africa, you can see in hospital mortality of about 0.5%. I think this is the scary part, is if you look at the comparable outcomes, we see that if you have surgery in Africa and you're an adult, you're twice as likely to die. If you have, if you're a child and you have surgery, the South African data suggests that you're 10 times likely to die compared to what happens in Europe. And if you have a cesarean delivery in Africa, you're 50 times more likely to die than in the US. That is actually the bottom line for perioperative mortality in Africa and South Africa. So we got a big challenge. So if you look at perioperative mortality rate, So from ASOS, we know that the mortality following elective surgery is twice that of the global average. And what we see is that the mortality following complications is also twice that. That means if you die following a complication, it's known as failure to rescue. And this is the important part about acute care, is that if you develop a complication in Africa, you're twice as likely to die from it. So there's this failure to rescue of double that of the global average, and this is certainly a real worry. So, you know, how can people get involved in global surgery in our context? So there are a number of things that we need to be focusing on. For governments, the challenge is to provide the NSOPs, National Surgical Obstetric and Anesthesia plans for the country. This is to create the infrastructure and the support to provide an environment for safe and affordable surgery. And governments need to look towards financing surgery, especially because it's cross-disciplinary and it provides other skills to hospitals for the provision of acute care. Again, funders play a big role, and they need to play a bigger role in supporting surgical funding initiatives. And the reason I say this is because when you look at mortality globally, the third most common association with mortality are patients who've undergone surgery within the previous 30 days. And that's higher than HIV, malaria, and TB combined. Civil society, I think, has got a big role to play in this. And this is really I apologize. I got dropped off by the network. This is my last slide. So, in conclusion, I think we've got the global surgery principles to guide us. It's clear that we have unacceptable surgical outcomes in Africa, but I do believe, you know, through APORG and through the N4PCc and the support shown by the Ethiopian Ministry of Health and by the WHO African region, that we really do have a network with the capacity to improve the quality of surgical care. So thank you for this opportunity.
Thank you, Professor Bruce, for the presentation. Now the floor is open for questions, discussions, and opinions. I can't see any question on the chat box.
If there are no questions, I'm happy for us to break for tea.
Oh, okay.
Maybe I can just make one more comment. I think, when we look at the outcomes, surgical outcomes in Africa, they're obviously very distressing. I don't think that should make us despondent. I think as a group, we're doing fantastic work. We are highlighting a very important area that needs to be addressed. We're responding appropriately. In other words, we're looking towards strategies to improve the quality of surgical and acute care in Africa. So personally, I think, although it's very distressing, what I've shown you, I think it's extremely important. So thank you all.
Thank you for the additional opinion. We have one question from Luca Ntasema. The question is to everyone. What are the strategies to implement telesurgery technology in Africa, especially Ethiopia?
Should I have a go? I know there are others on the group who probably will have very good opinions on this. So just from the perspective of APORG, APORG started with just trying to understand what's going on, in surgery in Africa, and we're certainly getting a very good idea quickly. And I think once ASOS-BEADS is complete, we'll have a very good idea of all surgical outcomes, children, adults, and mothers. And the second part is certainly we're looking at strategies, what can we do to improve quality of care? And part of that was ASOS2, looking for simple, generalizable interventions to improve quality of care. I think what ASOS2 has shown us is that improving the quality of care is it's complex. It's a complex intervention, basically. And so that comes to the answer to your question about telesurgery, etc. So certainly part of the findings of ASOS2 comes down to communication. Communication and I would say telehealth as part of that network of communication. So it's a space really that we as a group haven't worked much in yet, but certainly I think it's probably an area which will quickly become part of the strategy of trying to improve quality of surgical care in Africa, and different strategies for communication of surgery and surgical problems and surgical care. I don't know if anyone else wants to ask or comment on that question, or I'm happy to go to the next one from Tim Baker. Trunesh?
Yeah. Anyone additional idea? No, so let's go to the next question, Professor.
Okay, so Tim asks, how can efforts to improve global critical care learn from the progress by the global surgery efforts? So thanks, Tim. So I think the point, I think where what's been really good for the global surgery group was firstly the Lancet Commission and setting those standards. So the six indicators, which are now 5 because they've collapsed the 2 finance indicators. But setting the indicators gives one targets to work towards. I think that's extremely important. And to be honest, it was one of the impetuses which resulted in ASOS and APORG. was at the time, I think there were a lot of us who were really interested in what was going on, but the Lancet Commission gave direction. And the first thing was such a simple thing is, how many people die after surgery? And the reality is, at the time, we had no idea, which led to ASOS. And so I think, as soon as one's got common indicators that one wants to deliver globally, that's important. And then trying to answer them. And what's happened, I think, in Africa with us trying to answer some of these very simple questions is that we've built a network of clinician investigators who are invested in this and are really keen to improve the quality of care. And that is really, I think, what's been tremendously important for all of us. So there's another question on task shifting. Do you want me to address that?
Yes, please go to the next question. I don't see any hands raised, additional ideas.
Okay. So task shifting and task sharing, the concepts of providing healthcare by either non-specialists or non-physicians. So I think if you look at the slide I showed of specialists per 100,000, and us in Africa having less than 1 per 100,000 surgeons, obstetricians, and anesthetists, and we should have in the region of 20 to 40. To be able to get to that point is going to be impossible with physicians alone. So if you want to increase access to surgery, we have to embrace the concepts of task sharing and task shifting. So really the issue here is about how do we create an environment to be able to provide safe surgery and anesthesia when one is talking about task shifting and task sharing. And so formalizing training programs and trying to set up structures in district hospitals that support non-physician surgical and anesthesia providers is extremely important. I think one of the great papers to read on this topic is a documentation of the Tanzanian INSA process. So in that INSA process, they targeted a 25-fold increase in anesthesia providers over a 5-year period based on an increase in anesthesia physicians and anesthesia non-physician providers. So looking for one to support the other. And that led them to a total predicted anesthesia providers for the country of still only 2.5 per 100,000. And remember in my talk, I said we need 4. But this is a massive increase in surgical capacity, 25-fold increase. So again, at the end, we spoke about what can we do? Well, NSOPs is super important, but the experience, our knowledge of the workforce, and the example from the Tanzanian NSOP shows us that there has to be a place for task shifting in these plans. But it has to be also, we have to set a structure which allows for safe task shifting. And I think the Tanzanian NSOP is a very good example of this.
Okay, thank you. There are still more questions, but we have some announcements. Dr. Leah, Her Excellency, the Ministry of Health head has left, but there are the Ministry of Health members who are still there to answer our questions. If there is any question or concern that we should raise to the Ministry of Health of Ethiopia, there is also from the N4PCc. It's also that this platform is also running on a YouTube, so we can connect from that. The link has been shared on the chat box. There are more questions, Professor Bruce. What do you think and what has to be done to improve this great gap, particularly in Africa?
Which question are we looking at?
It's the one saying there's of implementational research in the regard about the research assessing patients' outcomes related to surgery and anesthesia. You've seen the question from Azmara Ambacho.
Oh, okay. Okay, so yes, I think that's a very important question. So, Asmara says there are plenty of research assessing outcomes related to surgery and anesthesia, and I agree. I think we've been doing a lot of that, and as I said, the most important area which we still do not know about is the children. And then it says, however, in my opinion, there's a dearth of implementational researchers in this regard. What do you think, and what has to be done to improve this great gap, particularly in Africa? So, as us do, which I think I will touch on in one of my next talks. But anyway, what we tried to do was try to address failure to rescue quickly and generalizably across Africa. And we thought if we could do this, we will at least improve some of the quality of the perioperative care and we'll decrease mortality. The simple answer is we didn't manage to decrease mortality. And it came down to exactly this question. It came down to implementation. It appears that even in what might be considered a simple post-operative intervention, the environment in which it's been implemented is quite tricky. And what you perceive as simple, actually, as soon as you're in the hospital, becomes complex. And so, the question, what do you think, and what needs to be done to improve this great gap in Africa? Well, we need to probably be focusing on quality improvement and implementation. And this is why the work of the N4PCc is so important. And I think their work has illustrated really nicely how, if you create a data network and you allow benchmarking, you can do quality improvement, and you can do it locally at sites, and you can benchmark your own activities, and you can improve and provide better care. And at the moment, what we're looking towards is a large quality improvement project for Africa, if you're talking about these postoperative or perioperative surgical outcomes. So I think that as Maru, that's probably the main area at the moment. Turunesh, do you want to carry on with some of the questions? You are muted. If you want me to stop and you want to go to tea, just do this and we can stop.
No, it's the host is muting my mic, that's why. More questions. Question from Iheno is asking how to integrate the service, especially the research area on critical care, with your organization and to work with you.
Okay, so thank you for that question. I think that's a really important question. I think probably the three very important things have happened. The first is ACOS was the first time the APORG network worked with critical care as well. And I think that was an extremely important project. It grew the network and it grew the critical care arm of the network tremendously. The second thing is, I think, again, the work with N4PCc in Ethiopia and their critical care work is also consistent with that need to build the critical care component, and that is also how we ended up at this meeting with a combined meeting with APORG and N4PCc. And then finally, we also have been working with a number of other critical care people across Africa within the APORG network, including people, for example, like Tim Baker and Arthur Quizera and others. So I believe the critical care aspect certainly is a focus as well now.
Thank you again. There is one more question out there. After ASOS and ASOS2, what are the next research priorities for the network or clinical trials in the pipeline?
Okay. So there are a lot of things going on simultaneously. So there's obviously the understanding the pediatric outcomes, that's ASOS Speeds, in the background trying to build this quality improvement project, probably starting at a pilot phase. So that's going on. You're going to hear tomorrow about the African Perioperative Network, which is basically how we keep all our clinician investigators together, informed, how we can make contact, how we can create groups, how we can do research projects together. So there's all that going on, and you'll see through that network, one can access the network. You can see all the projects that people are trying to work on, areas they're trying to develop. You can join them, you can show interest. So there's all that going on as well. And then there's this also commitment to this area of acute care in the perioperative and critical care space, which has also been developed.
Okay, we just had another question again. We're breaking for tea after this session.
Okay.
So answer all the questions and we go for a tea. It's a Siraj asked, I want to ask one concern, how the healthcare system implementation improved by the previous ASOS and ACOS trials. I mean, how the study contributes to the healthcare policy.
Thank you. So this is certainly an extremely important question, because it's pointless us doing all this work and it doesn't change healthcare policy, which is implemented and makes surgery and critical care safer. So I think the first thing we've done is we've created an awareness of the outcomes in Africa, and that's certainly important. That's important for advocacy. Despite the poor outcomes that have been demonstrated, and I'm going to discuss this, I think, I'm not sure if it's today or tomorrow, but what we've seen is that people have really embraced the work. People haven't been critical of the outcomes. What they've been more engaged with is that we've had the ability to show what's happening, which means now we've got a target on what needs to be addressed. And ASOS2 was the first attempt at that. But once we start to show success, one would hope then that these successes will be translated to policy. And that's why, I mean, from my personal perspective, it is extremely exciting to have been able to work so long with Ethiopia and the Ministry of Health. They've been extremely proactive and interactive in all these projects. And I would imagine that they would be extremely positive about integrating into health policies once we show interventions which are benefit.
Any other question or comments, ideas before we break for the tea breaks? I can't see any hands raised. All right then. There is another question, so let's break for tea. We have 20 minutes, so we'll be back after 20 minutes, like about 10:40, just 10:40, because we have 3
Thanks
other
very
minutes.
much.
Yeah. See you.
Thank you.
Welcome back, everyone. Now we'll proceed with Professor Rupert. Professor Rupert, as I've already introduced earlier, he was graduated in 1996 from St. George's Hospital Medical School, London, UK. After a time of working in general medicine and anesthesia, he returned to St. George Hospital, where he developed many of his current research interests and completed his training in intensive care medicine. 2006, he was appointed like a senior lecturer in intensive care medicine at Queen Mary University of London, and he was promoted to a professor. He has now given up on anesthesia to concentrate on his clinical duties on the adult critical care at the Royal London Hospital, and his research into improving patient outcomes following major surgery. Rupert has played a leading role in a number of large multi-center trials and has growing interest in global health research, including as chief investigator of a major global health trial of high versus low oxygen concentration in major abdominal surgeries. We will be speaking on what is global health, why is it important, and what percentage of it is an acute care. So for the next 30 minutes, we'll have a presentation, and then we have 10 minutes of discussion after that. So like we said, let's put our questions on the chat box, or we can raise directly on the screen as well by raising hands. Professor Rupert, you're welcome. Floor is yours.
Good morning. Sorry, just trying to mute myself there. And apologies for the slight confusion of not being able to get on. And thank you to Bruce for taking my slot so that I could still join you. A bit of a confusion at my end. It's all my fault, so I do beg your pardon. But I'm here now, and it's very, very kind of you to speak. Really, I see myself primarily as supporting others in global health research. And I feel very strongly that concepts of global health and the research we do and how that changes the healthcare that we deliver really has to be locally led. It has to be led from within the hospitals where it's happening, within the regions where it's happening, within the countries where it's happening. And there's lots of reasons for that. But probably the two really big reasons are that we are learning more and more and more just how important local context is. That my hospital may have differences to the hospital in London next door, or difference to hospitals in France, or difference to hospitals in Brazil. And we probably, as researchers, haven't understood how big that context is in terms of what we call applied research. Now, applied research is a kind of branch of research where we're actually looking at how healthcare systems work, rather than developing a new drug to treat maybe tuberculosis or HIV or pneumonia, or a new inotrope for patients who get hypotensive. You can do that research in pretty much any country, and it's still pretty much relevant to any country. Whereas applied research is very specific to the type of healthcare that you're operating within what type of hospital, what department, what country. And so context is tremendously important. And so leading the research with somebody who understands that context and leading the implementation of whatever we find in our research is really important for that local context. And so we need to find ways of helping people within countries to lead that work, but still making sure the quality, the standards, the rigor of that research is incredibly high. And of course, we know that type of research is extremely specialist, and it needs a lot of experience and expertise, specialist statisticians and economists and databases and people like me as well. So working out that collaboration, I think, is really important. I think the second reason why I feel very strongly that people like me shouldn't be at the front, but should be rather at the back supporting, is because whatever we find in our research and whatever we decide to do with those findings, whatever changes to the healthcare system, it needs to be sustainable. We need to improve things in a way that means that we don't come back next week, next month, or next year and find that that improvement was okay for a while, but we ran out of resources, we ran out of money, we ran out of staff, we ran out of equipment, or whatever it might be, and things went back to how they were. And again, you need people who understand the local context to help sustain improvements in healthcare. And you need people who understand what will and won't work in that context. Now, this may all seem sort of very specific to global health in low middle income countries, but we're actually finding very much this kind of logic in healthcare systems in high income countries. And I've done implementation research in high income countries, and it's very, very much the case that if we don't think about each individual hospital and each individual department and how that is different to other departments, that our interventions to try and improve things don't fit with the way they run their department. So it makes perfect sense that that same thing is going to happen in a global health context. And so it's very important that we are all engaging together on this, and that we encourage and support you within Ethiopia, but other colleagues in other countries within Africa to be leading that research and helping you to deliver it to the highest possible standard and disseminate it really well. But nevertheless, I'm really delighted to be asked to come along and speak, and I'll share what little I can to help you. So really, I've been asked to talk a bit about the concept of global health, how that relates to acute healthcare and how big a part of global health is acute healthcare. So, sorry, my keyboard is now misbehaving. So what is global health? Well, I guess it's what it says on the tin. It's considering healthcare not at a country level or a continental level, but thinking about healthcare concepts for the whole planet, for all of mankind. But I think in a UK context, the why the global health really is important is the notion of global health security. So I think for a lot of people, global health, well, it's not about the health of people in Europe or North America. It's about the health of people in low middle income countries, maybe in Africa, maybe in South America, maybe in South Asia, and so on. But actually, that's not what global health is. Global health is about everybody. And global health is a way of thinking about healthcare that promotes and helps people who live in high-income countries and perhaps don't think much about the difference, that gap in healthcare between high-income countries and low-income countries, to understand why everybody's healthcare matters to everybody. So, and I'll talk a little bit about COVID in a minute, inevitably, but it's really about global health security. That if we can ensure that healthcare, for example, across all of Africa meets a good, solid minimum standard, then that's going to mean that African healthcare systems are more robust, and when big problems come along, are better able to cope. Now, certainly that's been a driver for a lot of investment from the UK government in global health research, much of which has generated funding which has come to African countries, amongst others. And I think, I hope that everyone in the UK realises that the pandemic has only reinforced the necessity for that kind of work. So this is where I work. This is the Royal London Hospital. It's in East London. If you've heard of Jack the Ripper and the Krays, who are famous villains of old London, they hung around in Whitechapel. So for the UK, it's a relatively low-income area with lots of social deprivation, and quite a lot of high levels of disease in the local population, and a very diverse population, very multi-ethnic. So this is where we work. We're very lucky that our old hospital was replaced by this lovely big new blue box. Some people say it's quite ugly, but I don't really care because I'm inside it, not outside looking at it. So that's the hospital where I work, and you can see that it's placed on a junction between some of the wealthiest parts of the world. If you look down in the bottom left-hand corner of this map, this is the City of London. You can see the Tower of London here. This is Tower Bridge. This is where the London Mayor works, down in the bottom right. And this is this is just the edge of London's financial district. And you can see Canary Wharf, another financial district, on the top right. So sandwiched between huge centres of wealth generation, global wealth generation, with these huge international banking empires. And there's a place where there's actually quite a large amount of social deprivation. And one of the funny things about the UK is how poverty can coexist alongside tremendous wealth in some areas. So, you know, understanding that local population, many of whom come from low-income countries to live in the UK, and their families are moving back and forwards between those countries. They maybe come to the UK in middle age in some cases. They don't speak English as a first language. Perhaps they don't speak English as at all. They struggle to engage with healthcare. How do you register? In the UK, we have primary conditions, but how do you even register with one if you can't speak English? And what if you have an infectious disease and that's a problem for local healthcare in the local community? So our big local population from Bangladesh that live around the hospital where I work, their health in Bangladesh matters to the health of people in London, partly because they use a lot of our health resource quite appropriately, but you know, we need to think about, you know, how we can provide for them and make sure they have enough healthcare. And partly because some of the diseases they come with are infectious, and obviously we want to limit the spread of TB and other infectious diseases. So that's just one example of how, from a high-income country context, health is important. And I think for you listening today, the reason that's important is because this is how we get investment in research and improvement in healthcare systems in low and middle income countries. This is how we encourage people who live in wealthy countries to share some of their wealth in the investment in how do we develop sustainable, better healthcare systems in low and middle income countries, because it's good for everybody. And just to really hammer that home, this is where I've been for much of the last 2 years. We've been in a very well-resourced intensive care unit. That the top floor of my hospital had some vacant space and was turned into a huge intensive care unit. And the photo on the bottom right is just 1/10 of the area. So we had nearly 200 patients on ventilators in our hospital in this massive area. And it looked like something almost out of a, you know, a film, a thriller of some description, with row after row after row of patients with COVID on the ventilator. And, you know, everyone everywhere has had a horrible experience with COVID, but certainly we had a horrible experience with it in the UK. very high expectations of our society, but not always prepared to give us the resources we needed to deliver great healthcare. And COVID is the classic example of why we need global health security. Investing in global health is so terribly important for high-income countries. And this is important because it's an underpinning case for financial investment, both in research and in improving healthcare systems. So sorry to labor that, but I think it's a really important idea. And you know, that if you look, it goes beyond just people who have COVID. So this is surgical mortality in the UK over the period of the pandemic, some research done by one of my junior colleagues, Tom Abbott. And you can see that the green bars and the red bars were patients who had COVID infection, and the green bars are people who didn't. But you can see that there is a very clear signal of excess deaths from surgery during the big COVID waves that we experienced in the UK. So, you know, these pandemics, they don't just result in people dying from the infectious disease itself, in this case, COVID. It rocks healthcare systems in every sense. And everybody's healthcare suffers. And this is what I'm telling people in the UK all the time, that the pandemic isn't just about people with COVID. It affects everybody's healthcare. Whether you have a road traffic collision and come into hospital with trauma, whether you need diabetes care, whether you're having surgery, your healthcare system is not as good in a pandemic. And that is a really big issue, certainly for the UK, but for all high-income countries. If we then zoom and look at the pandemic in a global context, as I think we all do, you can see, you know, well, this numbers are a tiny bit out of around, at the moment, nearly 5.6 million people in the world have died from COVID. 5.6 million people. And without being political about it, when we think about how much money we invested in the response to, for example, the 7/7 incident in New York, and the number of people who died in that incident, and then we come and we find something where 5.5 million people have died, you know, are we investing the same amount of global resource in the problem? I suspect that it's not even close. So this is the map from the World Health Organization on the presence of COVID around the globe at any one time. And I just want to highlight, you can see here in Africa that the colors are quite lighter. Now, we don't know whether that's accurate, because this is based on reporting of data, and most countries have based their reporting of data on their ability to test patients to confirm that they have COVID. And if you don't really have the healthcare infrastructure to diagnose people with COVID, to treat people with COVID, you're not going to register COVID cases, and you're going to under-record the incidence of COVID disease in your country. And I've been watching this map change colours over the last couple of years, and I continually wonder how big an issue COVID is in Africa as an acute disease. And, you know, it may be because, you know, a lot of countries which are generally have a colder weather system than a lot of African countries, maybe COVID as an infectious disease is less prevalent in Africa. Perhaps, I don't know. It doesn't seem very likely that it would be that much less prevalent. It's much more likely that COVID is incredibly common in Africa, but we don't have the systems to measure it. And so we think that it's not a big deal. Whereas what's much more likely is that people are quietly dying of COVID and nobody notices it because we're used to those healthcare systems being under-resourced and not being able to deliver the care that everybody needs. And I don't think that's okay. You know, why should people in one country have amazing healthcare and people in another country have no healthcare at all? And this is one thing where you know, in the UK we can relate to, because, you know, if you go to the United States of America, they're very proud of the fact in some cases that they've got the best hospital in America. So one of my colleagues works in New York, and the website for his hospital says that his hospital is in the top 5 best hospitals in the United States. And they're proud of that. But the thing is that if you've got a hospital in the top 5, you've also got a hospital in the bottom 5 somewhere else. So if healthcare is amazing in one place, it's also rubbish somewhere else. And in the UK, we have a national healthcare system, NHS we call it. And in the UK, if somebody in one hospital has worse care than somebody in another hospital, it's considered socially unacceptable. It's not okay for people, say, in Manchester, in north of England, to have worse healthcare than people in London, in the south of England. And that will be brought up in the media, in the newspapers and on television, and people will be arguing that it's not acceptable to have differences in quality of healthcare across the United Kingdom. And that's conceptually very different to the United States, where they're quite proud of those differences. And I've never quite understood it. But to me, you know, if we understand the importance of having great healthcare across the UK, then why don't we understand the importance of having great healthcare across the whole of the globe? And I think part of that is because we don't understand how important it is for all of us that healthcare across Africa is really good. And, you know, there are relatively inexpensive changes that we can make to healthcare systems that could improve that. I think probably the most complicated thing to resolve is around staffing, but you know, with the right kind of sustainable investment, these are solvable problems. And we just need to recognize in high-income countries our responsibility to the whole of the planet to support that. And I think that's a really important issue. So what are the global health concepts for acute care? Well, I mean, this is no surprise to you. I mean, obviously, surgery is a big topic. Trauma is a big topic. Sepsis is really a funny word. It really defines something that people invented so they could do research. It's not actually a real thing. Most of the time, I prefer the term infection. Infection is a group of diseases that can make you critically ill. But I think sepsis is a very recognizable term, but it's a very misunderstood term. I also think that we need to think in the context of a healthcare system, critical care, because critical care is something that crops up all over the place for all sorts of different diseases. And in a system level, it's a bit of a safety net that's very important. And then finally, emergency medicine really, again, sort of overlaps with critical care, but it's a safety net for all the diseases that we see in acute care. And so sometimes it's important to think about the patient problem as the disease that the patient has, but sometimes it's quite important to think about it at a healthcare system level, label that by, you know, the care that we give or the job that we do, and developing it in that way. So I think those are some of the, really, for acute care, some of the most important problems. And of course, global health for so long has been heavily centered on chronic diseases or long-term diseases. So, you know, HIV and TB and malaria are, of course, tremendously important problems. And it's absolutely right that we invest in prevention and treatment of those kinds of diseases. But I think there's been much less recognition of how damaging acute care can be. And I think that there's also not the recognition that acute illness has a high chance of translating into long-term illness. So if you have trauma and you have a spinal injury, you have a long-term problem that you won't fully recover from. You know, and there's all sorts of long-term impacts of these acute harms that add to the burden of long-term disease for those people that suffer from them. So seeing acute healthcare as a driver of long-term illness, both for the individual, but also healthcare systems that have to support those individuals, but also the economy, their family, the risk of catastrophic expenditure in an acute sense for people who have to pay for healthcare for somebody, but then they're left with somebody who needs aftercare and there's no healthcare system to provide that, and the family have to provide that. And so acute healthcare is a really important driver of poverty, and better acute healthcare is going to be something that really improves quality of life in all countries. And so it's been quite neglected in the past, and it's good to see that we're starting to focus on it more. So this is one early attempt from our group to drive an understanding of surgical care at a global level. Whilst I'm quite proud of this study looking at surgical outcomes, you can see that it's obvious that there's a lot more to do in terms of our failure to be able to support and include African nations in that kind of research. Fortunately, Bruce and colleagues were able to resolve that with a follow-up study using the same model, this idea of a 7-day cohort study that didn't use too much resources to deliver the research. And ASOS really is a game changer for healthcare in all low and middle income countries, in my view, but obviously in particular Africa, by defining the fact that as a general rule, people having surgery in Africa were younger and were lower risk, but were twice as likely to die after surgery than those people in high income countries and compared to the global average. And as we seek to improve access to surgical healthcare for all, we can expect that if we don't improve the quality of perioperative care at the same time, that we'll see a lot more deaths after surgery. So there's no point improving access to surgery if that surgery is not accompanied by good quality perioperative care, because if a patient has a complication after surgery, that can completely negate the benefits of that surgical treatment. So it's really important that it's not just surgery, it's safe, good quality surgery with safe, good quality perioperative care. And I think ASOS really helped us to realize how important that is, and it's really helping us to make the case for better perioperative care. And so just the general concept of safe surgery, the fact that there's not the resources we need at the moment available to deliver that in the way we'd like to. I think that the very high burden of untreated long-term disease is a key driver for poor outcomes, and something that we need to understand of how we support, how does acute healthcare support the treatment of long-term disease. Now that's a big challenge, but when a patient with a long-term disease comes into contact with a hospital for an acute illness, what are we doing to treat their long-term illnesses as well? Can we solve that problem? And I think we can. It's very complicated and difficult to do, but it's an opportunity we need to find and take. But do we properly understand the geographical factors and how they vary from hospital to hospital, region to region, country to country? And sort of understanding not only the issues of access to surgery, but access to good quality surgery. So in a surgical sense, there's a lot there still to do to improve the access to good quality care. Then there's the notion of critical care and what the minimum standard of critical care is. And on the top right, this is a COVID intensive care bed in the hospital where I work. And at the bottom left, this is the high dependency unit at Mbali Regional Referral Centre Hospital, where some of my Uganda research collaborators work. And you can see the difference in technology. I mean, just looking at the technology of the bed itself that the patient is in, you're talking about completely different systems. And my fear for critical care it's incredibly staff expensive, it's incredibly resource expensive, and it's incredibly financially expensive. And there's a real risk that rolling out critical care for low and middle income countries could turn into a kind of a vanity project where we have a shiny building or a shiny facility, but it doesn't have the capacity to really transform health and well-being for large populations. And so we're really stuck there because we know critical care is really important as a concept for all acute healthcare, but we also know it can turn into something that's incredibly expensive very, very quickly. So how do we focus around the low-tech solutions to critical care needs? How do we deliver teachable skills? Now, how do we see critical care as not being about a geographical place in the hospital? It's not about real estate, but as a concept, as a set of skills that all our healthcare providers have. And so that's the big challenge around critical care. And I think that there are some groups making some excellent progress with this. You know, Arthur Kwizera in Uganda, Tim Baker leading some work from Tanzania with colleagues. So we are making really good progress with this. In his talk about failure to rescue. Failure to rescue is when a patient dies after surgery from a complication. And if you're having elective surgery, you would expect the overwhelming majority of people who have elective surgery to survive. Could argue that nobody should really die after elective surgery. Now, about 25, 30 years ago, there was the recognition in high-income countries that a lot of people did die after surgery. And when you went to the patient to look at what happened, the nurses were taking blood pressures and pulse rates and respiratory rates and writing them on the chart and not telling anybody. And you could see the pulse rate going up and up and up and the blood pressure going down and down as the patient bled out. And then they would have a cardiac arrest, and then people would come to help them. But nobody contacted a doctor before then and said, this patient is sick, come and see them, so that someone came along and diagnosed the bleeding before the patient had a cardiac arrest and prevented failure to rescue. So seeing a postoperative complication as an opportunity to stop a patient from dying. And to do that, we need something called capacity to rescue. And that means that we need both the resources and the training to identify people who are deteriorating after surgery due to complications and to intervene and do something about that. And so the concept of failure to rescue, I think ASOS showed us, is a huge driver of death after surgery in low and middle income countries, and it's been a major target for the research that Bruce has been leading in the APORG group. And one of the other big categories that I would focus on is maternal hemorrhage. And I think one of the reasons that maternal hemorrhage is really important is firstly because we are talking about often young, healthy women who are dying, who are creating poverty because there are children who aren't supported and don't have a mother to care for them. There are whole families who are facing catastrophic expenditure as a result of the death of a mother. But most of all, because it does look very much like we have a whole raft of interventions to prevent and treat maternal hemorrhage that we're not properly using. So this is a really great example of applied research, implementation science. We know what we can do, but for some reason it isn't happening all the time for every patient. And because it isn't happening all the time for every patient, a woman in Uganda, like this lady here, might die from maternal hemorrhage, whereas in the UK, it would be considered a catastrophe. And in the UK, death in childbirth is a huge, is a huge thing. It will be in the national media, and in regular reports of deaths in childbirth are reported in the national media. The expectation is that it should not happen. A woman should not die in labour. Now, if we think that about people in the UK, then why don't we think about that for people everywhere? And I think I can't see a reason why we wouldn't think about it that way. So, you know, I think maternal hemorrhage is a terribly important area where we need to simply start by using the knowledge we have. But to do that, we have to do something called implementation science, where we understand what is it that's stopping us using that treatment. Make sure it's not because we don't care, because everybody cares. Are there reasons why those treatments aren't being used? Is it because we aren't properly trained? Is it because the tranexamic acid is in a cupboard on the other side of the hospital and we don't know where it is? What are the reasons? Because we've learned in high-income countries that those kinds of reasons are actually big drivers for problems in healthcare delivery. And so through people like me, we can use the research learning from research that's done in high-income countries, apply the same concepts in low-income countries very effectively, because it's the same kind of research and it's the same kind of skill set to delivery. And that's what I hope that I am able to provide to the African Perioperative Research Group. And then a quick mention about humanitarian aid. This isn't quite the same as global health that we've been talking about thus far, but you know, there are lots of refugee centres across the globe, often in war zones, where there are humanitarian hospitals led by the Red Cross, the Red Crescent, Médecins Sans Frontières, and so on, providing emergency care and starting to think about humanitarian aid as a healthcare system in itself that needs improving as well. And so we're starting to do research with groups from these various charities to see what we can and should do to improve healthcare in that context as well. So this leaves us to different research themes. We need to do epidemiology to understand our populations and to count people across the whole populations. We need to do something called mixed methods research, where we don't just count numbers, but we actually go and talk to people. We interview people. Why couldn't you give tranexamic acid to that patient who was bleeding? What happened? You know, that kind of research. Or maybe watching people at work, that's called ethnography, speaking to them in their own environment. Something called complex interventions, and complex interventions are what we need to do to deliver these improved standards of care. So if you want to understand a complex intervention, there's a great analogy that one of my colleagues uses. So if we think about a pen like that, now that's a simple device, a simple technology. It's got no moving parts. I can take it apart very quickly and put it back together again, and there's not really that much to it. If you think about complicated intervention, that might be something like a racing car or a space rocket. It's got lots and lots of bits to it, but there's a design, there's a diagram that shows you how they all fit together, and you know, you can take it apart and put it back together again, and it will work in exactly the same way as long as you follow that design. A complex intervention is a bit like a teenager. You know, you can parent your teenage child and teenage children in exactly the same way and get a very different outcome every time you do that, because they don't respond in the same way every time. And complex interventions are designed for that third category, that if you do the same thing everywhere in every hospital every time, it doesn't necessarily work in the same way. So we need to understand that local context, and that's where the mixed methods research comes in, the epidemiology comes in, helps us understand the differences between hospitals, helps us design interventions with staff and patients who are based in those hospitals to design interventions that work in every context. And that's really, really important. Then we need to do things called cluster trials, which are the best design of trial to study complex interventions. And then perhaps in the future, we'll be designing new treatments that allow us to improve patient care. And through those, we'll do those more simple individual patient randomized controlled trials. And this is one example of an individual patient RCT that we're doing. This is called Penguin. Quite a few African countries are participating. South Africa is taking part. Ghana is taking part. Nigeria is taking part. We look forward, hopefully, to Rwanda and Uganda taking part as well. So, this is quite an important opportunity to study. We're studying chlorhexidine mouthwash to prevent pneumonia, and we're studying oxygen therapy as a prevention for surgical site infection. And it's a good example. Oxygen therapy is a resource-intensive intervention for many hospitals. If it works and prevents surgical site infection, we need to invest in the infrastructure to use it, because surgical site infections are a big problem. But if it doesn't work, it doesn't prevent surgical site infection, we need to not do it. We need the World Health Organization not to recommend everybody does it, because it uses up resources that we need for other patients. So a really good example of how global health research relevant to low and middle income countries, that takes place in low and middle income countries, can allow you to understand whether resource expensive interventions are worth the money, the staff, and the facilities that they use. So one final plug, this is a study in South America, in Latin America. It's LASOS, so we're just about to launch an equivalent study to the ISOS and ASOS studies that have been done before. And just realizing that actually, if you're in a low-income country and you're trying to improve your healthcare system, what you're probably doing is increasing your capacity of your healthcare system, increasing the volume of patients that you treat. When you reach that stage, you'll find that you've got a whole load of different challenges about improving the quality of healthcare. And as there are different countries at different stages of that pathway around the globe, we can anticipate that, for example, challenges that Brazil has as a middle-income country in delivering great healthcare will be challenges that, for example, the Uganda can expect to have as the healthcare system there improves. So sharing learning, not just between high-income countries and low and middle-income countries, but between low and middle-income countries within the global south, is an incredibly valuable approach. And that's something that we really want to see more of, is how low and middle-income countries share concepts and understandings between them to make the most resource-effective way of improving healthcare. Finally, plug for the African Perioperative Research Group that Bruce and colleagues set up, that's now really, I think, the envy of global health researchers around the world. It's been incredibly successful. And what Africa has achieved in perioperative care research with virtually no resource whatsoever is humbling. It's been a huge success. All credit to Bruce for being an amazing leader of it. I know Bruce will say that there are many other people who have helped, and of course there are all over Africa. People have been making absolutely superb contributions. And I just want to say that APORG is going to make a huge difference to the quality of patient care in Africa as the group starts to deliver research that really defines better ways of delivering healthcare. The research to date has really strongly made the case for the importance of research on these kinds of problems in Africa. And I can now announce formally that Ethiopia is one of 4 countries in a major global health research grant that we've just secured for research in Africa. And so Ethiopia, Uganda, Tanzania, and South Africa are the 4 participating countries, and we'll be delivering a series of large projects through APORG. And it's absolutely amazing that Ethiopia is going to be one of the key countries within that, and we're really grateful to FITSM and everybody who's helped support us putting that grant application together, which has allowed us to channel resources from the UK to Africa. And over 80% of the funds in that project grant will be spent within Africa. And so that's a really great success, and we hope to see more of these successes. And I see my job really was helping that finance to reach you, and being a channel for that, and to be giving advice and support for research and implementation science that you all deliver in your own local contexts. So next steps, yeah, we've got a lot of work to do to set up our NIHR Global Health Group. We've got some large, simple clinical trials to deliver. We need to still work hard to understand every hospital's healthcare context, and we need mixed methods research to do that. The APORG group is about to shift into a whole new phase, delivering applied health research, and is now in a position of having a very significant amount of funding to deliver that high quality research. So that's excellent news. And we need to start building links with other groups, such as the Global Surge Group that's seeking to improve surgical care, but other groups as well in critical care, in global health for maternal care, and so on. So we're making excellent progress in acute healthcare, but we've still got a long way to go. And I think I probably talked for long enough now. I'll be happy to take any questions. Thank you.
Okay, thank you for that inspiring presentation. Now let's go for questions or opinions. I can see any question on the chat box. Anybody? You can raise hands.
Can I just thank Rupert for all the support he's given us? He's shared selflessly, basically study methodology, mentorship, etc. And I don't think we would be here without his support and his mentorship. So thank you, Rupert. It's really appreciated.
Yeah.
Okay, some questions on COVID-19. Would you like me to answer them, Dronesh?
Yes, please go ahead on that.
Yeah, so a question in the chat highlighting the huge impact COVID-19 has had, and just asking some questions about that. So what special considerations need to be taken for people who will be undergoing major surgery, and what makes them vulnerable? So that, I mean, that's a really good question. The problem is that infection and prevention control within hospitals is incredibly resource expensive. It's expensive in terms of geographical resources, because you need to have wards and theatres that run what we call green. So in my hospital, we have a green pathway for people who've been shown to not have COVID, and only cared for alongside other people who don't have COVID by staff who've been shown regularly to not have COVID. We've got the people who definitely got COVID, and they're in obviously separate wards as well. And then there are people we call amber, and that's the people we don't know. Maybe they do have COVID, maybe they don't. And so you've got one hospital that suddenly has to divide into 3 hospitals. That's incredibly resource expensive. And of course, it doesn't work perfectly. You still see some people having COVID. So I think it's really, really difficult if you're running a hospital with surgical services, because you're going to, if you take extreme measures to prevent patients from getting COVID from after surgery, you will probably find that you are offering less surgical treatment to your patients. And in some cases, that may cause fatalities in itself. And I think it's a really, really impossible problem to square as to how we do this, because the pathways to keep people COVID free around surgery are incredibly expensive. They involve people isolating before surgery for several days. So people have to be able to afford to stay at home and not go out. And obviously people who work often can't afford to do that. They need to be regularly tested for COVID to prove they don't have it. And that can be difficult resource-wise, and getting both the testing, but getting the tests to the patient while they're isolating. And then of course you need these separate environments where people don't mix with people who do have COVID. And all of that is very, very demanding. So to be honest with you, I don't think there is a good solution for resource-poor hospitals in low or middle-income countries at the moment for delivering surgery safely within the pandemic. And I think that is one of the drivers that's going to keep the pandemic going. And until people in high-income countries realise that they're not safe until everybody's safe, I think that this problem is going to continue. So I know what the answers are in a very resource-rich context, but I just don't see how they're practical in countries where vast amounts of resource aren't thrown at the problem. Even in the UK, we are desperately short of staff at the moment to meet the healthcare goals that we've set for ourselves. What do you think needs to be done to reverse back to the catastrophic effect of COVID on acute healthcare, including surgery? So that's a difficult one. I mean, in the UK, we know a huge amount of people have not had surgery during the pandemic who would have had surgery, but they've sort of disappeared and we don't know why. Did they simply die at home of a perforated appendix? Or did they decide that they didn't need their hip surgery after all because their hip didn't hurt that bad and actually they're fine? A lot of these patients who would have had surgery have disappeared. And I do have a growing theory that in the UK that there may be a curve of the benefits of doing more surgery versus the amount of operations that we do on people, and that we may be close to the point where actually doing more surgery doesn't bring more benefit to our population, that it may even make our population less healthy overall if we keep doing more surgery, because you have more people who are high risk, older, have lots of chronic diseases and so on, having complications and then having a poor surgical outcome. So that, if you think about it, is the UK context. How that maps out in lower middle income countries, I think we're very, very unclear about that. But I would personally argue that it's the same challenge we've always had for surgery in lower middle income countries, and that's that we need more access. We need the scale of surgery to be increased quite substantially, and we need people to be able to access that surgery. And that surgery needs to be of good quality and safe. It doesn't need to necessarily be the kind of surgery you get in Mount Sinai in New York, or in the Massachusetts General Hospital in the United States, but it does in Boston. It does need to be achieving a good minimum standard, and I think that goes for all acute healthcare. So I would probably argue the challenge we've got there post-COVID is the same challenge we've always had, but hopefully we can use the pandemic to highlight that need. And I certainly think that organisations such as the Wellcome Trust have become much more aware of the need for critical care in Africa than they were before. And then number three, the challenge for emergency medicine, lack of essential life-saving drugs. I agree. As an expert, what alternative mechanisms the healthcare system should consider to counter this? So what I think the most important thing for emergency medicine is at the moment is the staff with the right training. I think the drugs are important, and I think equipment is important, but unless we have a small army of well-trained staff who are still present, who we are not losing to the well-resourced hospitals in the big cities, or who we are not losing to other countries, be they middle income or high income countries, then we're never going to solve the problem of emergency medicine or of critical care. And we've got to find a way of solving that problem. And I think ultimately it will be around how we make sure that trained healthcare staff are properly paid. And so that we reduce the problem of out-of-pocket expenses in acute healthcare, which is a big problem, and take it from there. So I think that I would start with the people rather than the drugs or the equipment, because you don't know how many drugs you've got. If there's nobody there trained to use them, they aren't going to solve our problem. I'm just going to skip down because I think there are some more questions from Salome. Oh, thanks, Salome. That's very kind of you. Everybody's health matters. Ethnography deep dive research zones. It may then be difficult to report, publish when they highlight local care issues. Well, so someone's highlighting that if you do local research in a local hospital, it may be hard to get it published. I think we need to fight against that. I think we need to prove to people the research we're doing is important and force them to publish it. And 20 years ago, when I started studying surgery in high-income countries, nobody thought it was important. Nobody cared about it. So we went off and did big epidemiology studies to prove that it's important. And now people do study it and they do fund it. And I think ASOS has had that impact for Africa. Hi, Lou, I see you've got your hand up.
Thank you, Professor, for an excellent presentation. I do have just one question. So you raised the issue of the evidence generation challenge that existed, especially the difference between global south and global north. And most of the evidence generation have been kind of derived from global north, the rich countries, especially when it comes to funding, like low middle income country researchers are so affected in that. And I'm just wondering, with your experience, you have been involving in a lots of low middle income research, and what strategy do you suggest for researchers from low middle income country, institutions from low middle income country to penetrate this really difficult and historic? It has been there, like with global health history. And yeah, any suggestion you do have around that? Thank you.
I mean, it's obviously a big challenge, and you will find researchers everywhere complaining that they don't have enough money. So that's a normal thing. I think that there are two big things that I would try and do. The first thing is to ask for what you need. So if you need access to statistics software, don't ask for money to buy it. Ask somebody to give you access to statistics software. If you need to go on a course, don't ask for money to go on the course. Ask for someone to let you go for free. And so on. If we need people to do PhDs, don't ask for the PhD fees. Tell the university, give me the place on this PhD course for free. By asking for resource, not for money, it's often much easier both for individuals and for organizations to give us the things that we need. But if you ask them for money, they may not have any spare money to give. And so the first thing is really think about, what do I actually need here? Is it money or is it a thing? Because somebody may be able to give you that thing much more easily than they can give you the money to buy it. And I think that's really important, because in research, as much as 75% of the resources you need can be given rather than bought, depending on the type of research it is. I think the second thing is that research everywhere needs buddies. It's collaborative. We need people to join together and give each other a leg up. And so I would encourage people to network through APORG, and that we use APORG more to bring in people who've been able to deliver research successfully at scale. and come in and help show how that's done. And also to play the role of a conduit for funding and to help you access the funding you need, to be that, in some places, quality assurance by being a guarantor that the research is high quality and well led, by putting their reputation on the line to support you. That doesn't stop people within Africa designing the research, leading the research and implementing the research. It is just somebody in the background going, these guys are good guys, they're doing great work and we should fund them. And I will take responsibility for making sure that happens. That gives big funders that confidence to invest. And so I think more people need to stand up and be counted in that way. There's a very good question from Tim Baker about critical care and picking up on the issues of vanity projects. To be honest, do I have time to briefly answer that?
Okay, then just respond to that question and then we will move on to the next session.
Sure, I've talked for too long, I realise, I'm sorry. So Tim just highlights, how do we get health policy makers to focus on, often quite unglamorous, low-tech interventions as opposed to big, exciting, shiny buildings and vanity projects. I think that we need to think about health policy makers, be whether they're politicians or local hospital managers or whatever they are. We need to try and think in their shoes. How are they trying to show people that they're doing a good job, and try and understand them better and understand what their drivers are, and then try and make the thing we know people need look like the thing that they want. How can we make, resource inexpensive critical care, low-tech critical care, look like a shiny building that they can announce as a success to their people who vote for them or whoever it might be. I think we really need to think about that, what the policymakers need from us, not just to implement, but to actually allow them to be successful. Because if they are getting something from us that helps them, then they're going to want to work with us. They're going to want to use our research and they're going to want to implement it, because it's a driver for them to be able to show that they're doing their job well. And we all need to show that we're doing our jobs well. It's important for all of us. And if we think of policymakers as people who have needs as well, and we think about what those needs are, I think we've got a much better chance.
Great, thank you for that.
Introduce myself briefly while we're waiting. My name is Catherine Chu, and I'm a surgeon, and I'm the director of the Center for Global Surgery here in South Africa at Stellenbosch University. The topic that I'm going to speak on is about Africa and global health research. And I'm going to take a step back from that amazing talk by Rupert Pierce and talk about research in global health and African scientists in general. I would like to say that if all high-income research relationships were like the ones that have been established with Rupert, then I wouldn't really need to give this talk. But unfortunately, at least in my experience, they aren't all like that. And so that is sort of the basis for some of my talk. Where can I start sharing? I see that I'm a co-host, but I was wondering if you could help me out by telling me where it is that I need to go to share. Oh, never mind, I got it. Okay. Okay, so again, the topic of my talk is Africa in the context of global health research. So first, to put it into perspective, so Africa, we have 15% of the world's population, but we have a much higher global burden of disease, non-communicable diseases being a significant part of that, with many surgical conditions following into that and acute care conditions as well. But unfortunately for us, we produce less than 1% of the biomedical publications worldwide. And somebody once told me that there are 4 characteristics of effective research. The first is individual research skills and ability. The second, and this is really important, is appropriate infrastructure. So here in Africa, those of us that work at universities don't always have the administrative or financial support to set up a research team or a lab. We don't have the statistical backup, and we don't have grant writers that can help us apply for money. The next important is to be relevant to national policies. And then lastly, effective research needs to be able to contribute to the global research and policy needs, which obviously, as Rupert had discussed in global health, to research health conditions that affect people in different countries. So the real question for the talk today is, how do African scientists become effective global health researchers? So the first thing to discuss is the Global South, Global North research collaborations, because I think that this can be a real benefit to those of us in the Global South, but also sometimes, if not done well, can also be a real hindrance. So just to recap, global health is the practice of improving equity in health and well-being worldwide. And global health research is the study of how best to achieve this. And historically, global health research has been dominated by the global north, even on topics about Africa. So a recent paper published by Lee Wallace and his group about the COVID pandemic showed that 1 in 5 African COVID papers had no African authors. And more than half of the authors on these papers about Africa were not from Africa. So some of the extractive research pitfalls that some high-income research, again, not all, can fall into working on the African continent. And I don't know if any of you colleagues that are listening to this talk have ever had this experience, but I certainly have. So the first would be the taking of data without local permission, ownership, or capacity building. An example of that would be a surgical registrar, anesthesia registrar coming to rotate one of our hospitals but it certainly has happened in the past. The second one would be slightly more egregious, and that would be the taking of human tissues without local permission or ownership. And sometimes that's called mosquitoes research, where they come in, steal some of the blood samples, not steal, but take the blood samples, and again, do data analysis, basic science analyses on those specimens without any local permission, ownership, or capacity building of the local research team, if there is even one. The next point is that extractive research, if not done collaboratively, could not be locally relevant or appropriate. And Rupert touched on this a bit, but really only the local clinical teams on the ground know what is relevant. So, for example, sometimes there would be drug trials conducted in low and middle income countries here in Africa, but not necessarily that relevant for our context. This can result also, these type of extractive research, in no local authorship, no local dissemination. So the papers, the results could be published in very high impact international journals, but not always read by local clinicians or policymakers. And so did the results make any difference to the study population at all? And finally, and I think this is probably the most difficult, but probably the most important to discuss, is that was there any real local research capacity building? So for sure, in some relationships that are not equal, there is what I call token authorship. So the external team comes in, they do make some local collaborators authors, but was there any capacity building imparted during that relationship? And I hope that relationships like the one that Rupert has described will now get away from that. But in the past, I think there have been relationships like that. So the two problem statements, I think, are research relationships between Africans and high-income researchers are not always equitable. And currently, African researchers are not leading global health efforts, even on conditions that predominantly rise from our continent. So how can we change that? Well, first, let's address equitable global health research collaborations. And again, that's sort of what I'm talking about is between Global North collaborators and Global South collaborators. Again, let me highlight the positives of collaborating with folks in the Global North, like Rupert. Or sorry, Rupert, because you went ahead of me. I'm going to keep using you as a positive example. So global health researchers have been doing this for a long time. They have at their disposal quite a lot of resources, both financial, but also knowledge, statistics, methodology, research design. And many of the research topics in global health, and particularly in acute care, have been researched in their countries and can be relevant to our context. So we certainly are not saying, or I'm certainly not saying, shy away from research collaborations with the Global North. They have a lot to offer. But I think the questions are, how can African institutions and physicians benefit from international research collaborations without being exploited? How can advancement of African research capacity and academic careers be prioritized while still satisfying the publish or perish mandate of high-income universities? And I think that second part is something that we must acknowledge because I think it could be the elephant in the room. High-income researchers also have targets that they need to meet in their own countries, and that is also grant acquisitions as well as authorship on papers. And so we must feel that these collaborations are a win-win for both sides. And then finally, how do African scientists and governments coordinate the great influx of high-income academics who view the continent as the next frontier in global health research? So in some of the contexts in which I've worked, certain countries are sort of becoming very popular as the study populations for global health researchers. And sometimes the teams on the ground can feel overwhelmed, but also feel very complimentary that so many groups from high-income countries want to work with them. But how they navigate and coordinate and try not to offend the different groups that are coming can be challenging, especially if there's some overlap in the topics that are being researched. So sometimes, they want to say yes to very prestigious University A, but University B, also very prestigious, has also come in wanting to do the same research, but you don't feel like you have the power to say, okay, well, we've already working with this group, how can we all work together? So I think there are 7 different areas that I think could really help in trying to make these relationships equitable. The first would be to really focus on building local capacity, but using the high-income resources and the regional resources that could be offered at your disposal if you do have a high-income collaborator. So the first would be access to distant learning resources such as online libraries, courses on protocol development, statistical courses, data development and management. I think Rupert mentioned if these are being written into a grant to specifically ask for these courses for free as opposed to the money to take them, and I fully agree with that. The second is Hinari. I think hopefully most of our Ethiopian colleagues know about Hinari, which has really opened up access to journals. I think if you don't read about your topic, it's very difficult to become an expert in that field. And then finally, there are multiple South-to-South training opportunities. Groups like APORG now setting up so much research capacity here in South Africa and working with different research groups now all over the continent. I think Bruce has done an amazing job setting that up. There are universities here in South Africa. I'll give an example. I know Salome Masimwe at UCT, they have lots of training courses being offered. At Stellenbosch, there's also courses on clinical epidemiology, health policy and management. And some of these courses could be much more affordable for African colleagues than going to a high-income country. Setting the local research agenda, and I think this is really important, and I think Rupert also highlighted this, in having the local teams really drive the agenda setting. And I think only the team on the ground can know what is relevant to them. And I think that is really important. Local research committees can be set up to do this, certainly understanding the local priorities. I think in the past, and hopefully it's changing, but a high-income researcher will come into your area, for example, interested in diabetes. Now, diabetes happens to be a major health priority in South Africa, but it may not be in every context. And so they bring in their research priorities, but it would be really important to set up local priorities And I think for me, I also think that discussing with the local communities what their priorities are, so not just the clinicians, but the study population as well, the potential study populations would also be quite important in local priority setting. And I think this type of community engagement is being pushed much more by funders as well. And then finally, setting a local research agenda, but discussing that and then eventually dissemination to the local and regional ministries of health is very important. And then just to mention, of course, Global North partners can certainly participate in this, but I think this process should be led by the local partners. So long-term collaborations. And so there are many examples of very successful, equitable, high-income, low-income research collaborations. And I think Rupert and Bruce have one of them. But I certainly think that long-term collaborations build trust, and they take a while to set up. But just to say, they all start from somewhere. And so sometimes they start from personal relationships just between two researchers or clinicians, and eventually can build to very large formal partnerships. So two examples, not necessarily in acute care or surgery, are one from Uganda, the Rakai Health Sciences Program. This started with just two researchers, one from the US and two clinicians from Uganda working together. And they initially started on a very small community kind of cohort study. And eventually this became much bigger to clinical trials about community participation in studies. And now they've really established a multi-million-dollar research partnership. Similarly, some of you have heard of KEMRI in Kenya. This was set up between a Canadian and a Kenyan researcher initially. They do a lot of malaria and HIV work, also now receives a lot of funding and has trained many researchers now from LMICs. And then the last thing to mention is twinning now. So twinning is sort of a new model that I think can have a lot of potential in research collaborations, where typically it's the high-income country university that initiates an effort to link up with an LMIC university, again, sometimes starting from a personal relationship. But I think that then if the two universities have sort of a formal agreement of how that partnership will work, and that has a trickle-down effect into individual collaborators. Often built into these twinning MOUs is the need and the prerequisite that trainees from the LMIC also are able to go to the high-income country for formal degrees and courses. Because I think in the past, a lot of it was a bit one way. High-income researchers and their students could come to the LMIC to do their projects, but there wasn't much traffic going the other way. So I think sometimes built into these twinning relationships is that. Local coordination and monitoring, again, when I mentioned about the research duplication, some study areas are very popular for competing Global North researchers, but a local team could coordinate this. Rwanda does an excellent job of monitoring all studies or all potential studies coming into their country. They have a medical board that looks at all that, and they always ensure that the studies are in line with preset local policies and priorities. To tag onto that, having a local IRBs. Again, this really looks into our local vulnerable populations and prevents exploitation. Again, some of these ethics and vulnerabilities may not be known by researchers from high-income countries because they don't know the local context. And for sure, it can control the material transfer of the human tissues. So here in Africa now, we are able often now to do our own genomics, as during the COVID pandemic, we see that in South Africa, found the Omicron first. So human tissue doesn't always have to be sent out now. And I think that trying to keep some of the data and tissue analysis here on the continent also builds our own capacity as well. And then finally, to talk about the local authorship. So I think it's really important in equitable collaborations that the African co-investigators get involved in every step of the research and not just the final paper. I think that is really important. And I think that's the dynamic balance that's sometimes a bit challenging because it takes time and it takes, well, I think it takes money, although Rupert says it just takes trying to get people on courses, but it takes effort if you have a collaboration between high income and low middle income universities to make sure all the African investigators have the ability to participate in all these steps. because I think there's often a desire to participate, but there isn't the knowledge of how to do so. Hopefully that'll mitigate the extractive research. And then the really important part is that the local authors get a chance to disseminate the results in their own backyard, and also to present at conferences. So in the past, because funding to attend international conferences could be an issue for those of us in Africa, attending local conferences was a great way to present the results locally and regionally. Although now I would like to say with Zoom, a meeting like this, African participants can also present on the international podium. And I think that is also real important for equity. So I got a recent publication, and this was termed African-led health research and capacity building, sort of the 7 criteria that they felt were important to build African research and leadership. And the first was to identify trainees. So it's really important to train a cohort of African research scientists. And I think it's quite important to identify those early on in people's career. Not every clinician or every wants to be a researcher, but I think some do. And I think it's important to identify them early and find time for them to build up their research skills. In the US, for those interested in research, at least in surgery, residents or registrars get 2 years to hone their research skills. And I know here in Africa, we don't all have that. The second, of course, would be to have the African-based researchers lead their own scientific projects, publication with local authorship, discussed that before. Number 4, and I'll touch on this again, I think this is really important now, to lead grant applications. There's more and more recognition that from an LMIC. And I think this is a real chance for African researchers to get in the game, because by doing this, you will learn from your high-income colleagues and then eventually be able to lead one all on your own. The next is developing local infrastructure. And I think this is what costs the most money. And I think this is maybe the hardest for grant funding to fund. But I'll end with an example of how this has been done, is that local universities really need the money and the investment to build up solid research groups. So again, this includes statisticians, this includes folks to run the projects, this includes money to help manage the finances, this includes grant writers as well. And I think that without that, I don't feel that here in Africa, we are going to be able to compete on the international arena. The next is to engage local communities. I think that this is something that's really improved a lot, but I do feel that trying to understand your study population will really help make research relevant. And again, I think the advantage of those of us working on this continent in global health research is that we are much closer to the communities than our high-income colleagues. And then the last one would be to produce new knowledge and influence policy and practice. So I think that all this research is useless if you don't actually make a change on the policy or practice in your own country or in your own region. So I wanted to end, this is my last slide, to talk about some very successful funding of African-led research. And this was external funding. So the first is an example from the NIH from the US. So there have been 2 programs there, MEPI, which has been funded by $135 million US, and this is to train local African scientists. And the other one is the Human Resources for Health grant, sponsored in part by PEPFAR and in part by the CDC, and that's been given $180 million. The other one that I'll go into a little bit more detail on is through the Wellcome Trust, the UK government, and the Gates Foundation. There has been money into what's called the Deltas African Initiative. This primary objective is to help build infrastructure and train local young African scientists. That money has been mostly given to the African Academy of Science, and the African Union Development Agency helps to manage that. But the idea is to really have the ideas generated from African scientists themselves. One small branch of that is SAMPI, the Sub-Saharan Initiative around TB research. So they received $11 million US, which in terms of grants may not seem that big, but they have shown in the last 5 years, they've managed to have 119 publications. And most importantly, they've trained 105 African fellows, including masters, PhDs, and postdocs. And of these publications, 42 have been first authors by these fellows. And so this is, in my mind, a very positive example of how, starting with external funding, African scientists can be really trained up. I also want to mention that the whole Deltas initiative is also to put money into the infrastructure of the universities with which they work in Africa. And I think that's really important. A lot of this funding, at least historically, has been going to communicable diseases such as TB, HIV, and malaria. But I think Rupert and Bruce's example of their most recent grant, congratulations on that, shows that the tide is changing, and that studies like ASOS and studies by Global Surge can show how important surgical care and acute care conditions are as well. And we certainly hope that in the future we would be able to tap into some of these. That is the end of my talk. Just want to say that Global Health has put a focus on African healthcare, but Africans need to lead African-based research. We need to drive our local agendas, develop our local research capacity, and harness equitable high-income and low-middle-income partnerships. And finally, succeed in independent grant funding. I would love to entertain any questions, as well as to hear if any of you have ever had any of these experiences, positive or negative, that I have shared. Thank you very much.
May I ask a quick question to Anish?
Yes, yes, of course.
Catherine, I thought that was an absolutely fantastic talk. Thank you so much. And sorry for overrunning on mine, by the way. I couldn't find my clock and I didn't know how long I had been speaking for, but then I found loads of messages from Turanesh to shut up. The issue of credit for research going to the people who deserve that credit is so important. What do you think people like me should be doing? I mean, I'm sitting here in London, and I'm a co-author on lots of global health research, and I worry a lot about whether I am somehow disproportionately represented for the successes that this research delivered, when actually, often I feel like people are doing the real work and people in the hospitals themselves in Africa. What should people like me be doing so that we get that balance of helping and taking credit right, that we don't take more credit than we're entitled to?
Yeah, thanks for your question. So I would probably answer that in two parts. The first is like, how can we be helpful? And I think that at least in my experience, so maybe not for yours, sometimes the partnership starts with the high income person with their own, they have a grant and they have an idea that they bring to the LMIC researchers. And they do make a big effort to ask, like, is this something you could do? Is this something you'd be interested in? But I think that's oftentimes the answer is yes, 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 because the LMIC researcher wasn't quite sure how to think of their own idea, or didn't have a grant that they could also apply for, and had just no idea how to apply for one. So I wonder now, if you're in the position, if you could perhaps start more open-ended with some of your colleagues. I mean, I think Bruce is a shining example, because he certainly isn't a person who, has any of these deficits in terms of research and has his own ideas. But ask your research partners, what are the gaps in your own research capacity, and how could we support that with the next grant? Because I know that some grants are purely about research capacity building, but obviously you have projects tacked onto that are ongoing that you do in order to build the research capacity, but some grants are specifically for capacity building. So perhaps just to ask, like, what is it that you're shortcoming? Is it stats? Is it you have no idea how to design your own project? Because I'm sure that there's a lot of clinical ideas. And then I guess the other question about the credit, I would turn around and ask you, what do you think you should be doing about that?
Sorry, I mean, I genuinely sometimes think that that we should just be helping and not getting any credit at all. It's a real quandary, because to some extent the driver for the money is the university in the UK getting an academic success out of it. And so for me, the academic success is a lever to get the money and to use my university to get the money. If the university is getting an academic success, they don't mind me applying for the grants and spending it in Africa. But I also know that for a lot of people in any country who do a lot of the work on the front line in terms of research, seeing some person who at the top is getting the credit all the time can sometimes be very demotivating.
And I think, sorry, and I think that there is a real, not a conundrum or tension, but I think we do have to acknowledge that the way the systems are set up in the UK, the US, is that you cannot be completely invisible. Otherwise, you'll never get the next grant that you want to use to help build more capacity. So there is a group, CUGH, the Consortium of Universities for Global Health, and there's a specific committee about academic promotions around global health research. And the exact question they're trying to tackle is there a way to change the tenure track requirements for global health researchers? Because by definition, if you are trying to capacitate your colleagues in LMICs, you are losing points on your own first author, last author, for example. Yeah. And is there a way to give credit for time spent teaching a course, but no publication out of it, or time doing, helping someone else get a grant that still would credit you, because it's still, you still have to survive in your own context. But this committee is quite interesting because it has quite a few associate deans for teaching and learning in the US, at least. So perhaps they can change their own policies. But I think for now, it is a conundrum, yeah.
Could I just encourage you to keep talking about this issue, because the people who need to say this are people in Africa. Please keep highlighting it, keep talking about it. Don't be worried about offending. Just bring it up more, and it will be much easier to solve it when people are more aware.
I see that there's a hand up. There's also a couple questions in the chat that were sent directly to me. Should we go to the hand first? I think it's Dr. Tamiru.
Hi, Elon, yeah.
Yes, thank you very much for an excellent presentation. I really loved it. I was going to ask what just Professor suggested. What should be done, like in Africa, especially academicians, researchers from Africa? I think we need to have this voice. We need to start like asking how to decolonize this global health arena, especially when it comes to what you have mentioned, the capacity building. It is not happening. It was not happening for a very long time. Even when the concept of global health initiated, it was not for the low middle income country or the global south. It was for the global north to benefit, like to just keep exploiting what is going on in the era of colonization. So even our academic environments are not that alert. And my question to you, I don't know if there is answer to this. What should be done in our mind? I think decolonizing things start in our mind, and what should be done in to kind of this to initiate all what you have been saying, or to have all this energy and to stand up for ourselves, to speak up and say, even though it could offend some of our paternalistic donors and possibly lose grant because of what we said. Thank you.
Yeah, I mean, you make an excellent point, and I'd certainly love to hear what other colleagues speak and say. But I think the first thing is to get our own ducks in a row, or prepare our own backyard. So, for example, having local research ideas and priorities set up. So I think that if we have a potential funder coming to you, or a potential collaborator, and sometimes collaborators come with sort of very open-ended and say, we'd love to work with you. If we've got this idea, but if you say, well, we've got these 10 ideas already, and we've already looked at them, and this is what we'd like to do, but we don't have any funding, would you like to partner? I think that would be really helpful. I think the other thing is to know exactly what gaps and deficiencies you have in terms of the training that you want, and if you can, be very specific to your high-income partner. Sometimes these relationships take a while, and I think you mentioned a really important thing, the desire not to offend. And I think that I have been working in some places where I have seen that the local clinicians and scientists do not want to offend, and they will allow the high-income people to do pretty much anything. I mean, I'll give you one clinical example, so it's not research, but I was working in a place where a very famous vascular surgeon came and wanted to teach dialysis access, so AV fistula creation, and we didn't have dialysis in that entire country. But he wanted to have all the registrars in theater, found a patient, and made this to show everyone, but never once asked, is this appropriate for the local context? But on the flip side, the local head of surgery did not ever say, we don't need this procedure to be taught. We need these other procedures to be taught. So again, it's that balance of feeling like you have the power to speak out. The second thing, and I'll address, because this relates to one of the questions, what are the potential roles for ministries of health? So I'll mention Rwanda again, because they have a very strong Ministry of Health who has set up a specific Rwandan medical board so that every research collaboration or potential one coming into their country gets reviewed by this board. And at the very least, there has to be local authorship on all the papers. But again, as I mentioned, that's only really the first step to equity, because you could just put anyone on the paper. But I think that, as ministries of health, it would be quite important if you were able to help regulate some of this. Sometimes it's just a bit of a circus of all the different groups coming in. I hope that answers a bit, and maybe someone else wants to comment on this too.
Since that we're running out of time, what will we do? Maybe you respond to the questions on the chat box? Or...
Sure, okay. I'll just take this last one more question. It was, how do you help local researchers when they want to address local priorities to starting operational research in their countries? And I think that this is a real conundrum as well, because often you are a local researcher, doctor, clinician, you have your own problem that you see, but you're not so sure how to get it out to the world, or how to get someone in a high income country or a grant for yourself. And I think that comes down to data collection. And, Bruce Bickert, I'm sure will talk about this a lot, but if you don't have data to show the extent of your problem or your outcomes, it's very difficult to tell the world about it. So importantly, even if it's the most basic data collection, try to record and keep that, because if you're able to do that, even if you're not so sure how to move that forward into a paper, at least you'll be ready when someone wants to come and collaborate with you. And I see Bruce has his hand up. I don't know if you want me to end on him, or
maybe Professor Biros say something. Let's accept that.
Thanks, Catherine. I just wanted to actually support what Catherine was saying, and on this question in particular. So I spoke earlier on how we're trying to develop this African Perioperative Network, which is this data, basically a data network, so that we can connect all of us together. And the question about, about researchers and support and that, and the idea with the African Perioperative Network is that you log into it and you say, I want to do some research on breast cancer. And you can put down, this is your interest, And essentially, you can find other researchers across the continent who've got similar interests, and you can set up projects yourself to start looking at these problems. And in that way, I think you can also find mentors across the continent who are experts in the field. And so that's a long-term vision of this perioperative network. It's to enable all of us to, initiate projects and do them and build networks of interest groups. That's the first part. And then the second part is about what Catherine was talking about now, about tracking, auditing and tracking what we're doing. And that is one of the projects which has been running in the background, trying to establish a minimum data set for perioperative care and surgery in Africa, which is the Delphi part has been done. So that is in the process now. And the first part would be a minimum data set for tracking perioperative mortality in Africa. So we can start benchmarking our own practice and use it for quality improvements. So very timely question and great to answer, Catherine. And just look out for more. You'll hear more through the meeting.
Thank you all for that. Let's see now. Becker will be presenting on on essential emergency and critical care with a global context.
Very much. It's an honor to be here and present today. So I am talking to you from Dar es Salaam, Tanzania, where I am working at Muhimbili University of Health and Allied Sciences, and also at Ifakara Health Institute. And I'm going to talk to you today about this topic of essential emergency and critical care, and basically follow on quite a lot from the previous speakers to make the point that if we're interested in the care of critically ill patients, we shouldn't mix that up with high-tech ICU care necessarily, that there are opportunities for real impact at the more basic level. So I'll talk a bit about critical illness, the care we can provide for patients with critical illness, and then on to this idea of essential emergency and critical care. All of this is in context. Bruce presented the very nice Lancet commission on surgery. There was also a commission in 2018 on high quality health systems, which is very relevant for everything we're talking about at this conference. And that commission found that there is problems with care very commonly across conditions and settings. And actually the quality of care provided in health facilities has become a bigger problem now in the world than the well-known problem of access to healthcare. So this commission estimated that if we could introduce high quality health systems in all LMICs, we could save over 8 million lives every year. And they emphasize the need for research in this area. So that chimes with everything we're talking about today. The area of interest for me and for lots of us, I think, here is these patients who have critical illness. And if you define critical illness in the broadest sense, it's the patients who are sickest in the system, which is the surgical patients, but also patients with other conditions, infectious diseases, maternal conditions, non-communicable diseases, and so on. So it's the sickest patients, or the patients with whose vital organs are starting to become dysfunctional, and they have a high risk of death in the very acute phase if care is not taken. And also an important aspect of this is the patients who have some potential for reversibility. We're not talking about the patients at the end stage of life, the terminal patients. So this is easy to see in a model like this, where you can see the conditions on the left, including the surgical conditions and other acute conditions. When they get sick enough, they develop these different kind of syndromic problems like hypoxia, like shock, unconsciousness, or blocked airway. And it's these patients who are the critically ill ones. How much critical illness is there in the world? It's actually quite challenging to come up with good estimates. There was a recent estimate on sepsis, which is a common form of critical illness, that there are 11 million deaths annually each year. And there's also estimates on how many cases there are. also using methods that have their limitations, but estimates of 30 to 45 million every year have been stated. Different methods that we have used in our group, looking at how many patients within hospitals have critical illness in different settings in the world, has shown that roughly 12 to 18% of in-hospital patients are critically ill, so a very large burden that hospitals are dealing with, and the mortality of these patients is somewhere between 15 and 30%. So it's a real problem in the world. COVID has kind of seen a surge of critically ill patients and of interest around critical illness because of this well-known pyramid that was shown at the start of the pandemic, that these critically ill patients in COVID, who are known as severe or critical COVID, make up about 20% of the COVID patients. So critical illness has never been talked about more in the world than it has in the past 2 years, I would say. So if we move from there to think what is critical care in that way, so the definition I would like us all to try and think of it as is basically any care for these critically ill patients. So it's the identification, monitoring, and treatment of the patients with critical illness. And it often includes the initial and sustained support of vital organ function. So real kind of focus on saving the lives of the patient, keeping them stabilized while we're waiting for the patient themselves or their other treatments to get the patient better. And a model to try and see how this fits into other terms in this field. I would say all of these terms are within the kind of domain of acute care. So we're not so much talking about chronic care. But within this acute care, we have emergency care, which has its focus on the timely care. So it tends to be the care on arrival to hospital, or the kind of quick care needed for patients. But they don't need to be very severe. They can have a non-life-threatening disease. And then you have critical care, which has its emphasis on severity. And these two, of course, overlap. So you have patients who need quick care and are critically ill, and that's the overlapping bit in the middle. And this tries to show that there's a difference between critical care and intensive care, the care in an ICU. Intensive care is then a subset of this critical care. And then intensive care would be defined as the high-tech, high-sophisticated, expensive care in intensive care units. So it'll be interesting to hear other people's take on this sort of Venn diagram, and whether it chimes with how other people are thinking of these terms, or whether there are differences in there. What's critical care like currently? Well, we know that there are substantial deficiencies in many parts of the world. There's a lack of systems to provide, this is particularly in COVID, have been highlighted, the advanced respiratory support, so mechanical ventilation, high flow nasal oxygen, and CPAP in many places. A study from Kenya at the beginning of the pandemic said only 58% of beds were in hospitals with an oxygen supply. So what we know is critically ill patients are most often managed in general hospital wards. And this is a crucial point to think. If we want to improve the care of critically ill patients, we must be looking at improving the care in general hospital wards rather than looking in ICUs, because there's not so many patients in ICUs. If we look at Malawi, particularly, where I worked for a number of years, before COVID, there were 25 ICU beds in the country with a population of 19 million. Which of course is far lower than high-income countries. And the whole country only has 5 specialists in anesthesia and intensive care, and very few ICU trained nurses. This means that intensive care in Malawi is usually done without arterial blood gases, without capnography, other high-tech devices and equipment, and with very few investigations to be able to guide the care. And actually, the main challenges for the clinicians in these settings is basic things such as the supply of oxygen failing, or power outages and equipment breaking down. So once again, the point, and in Malawi, we did a survey and found that 90% of all critically ill patients in Malawian hospitals are outside of ICUs in the general wards. This finding is maybe one of the main ones as a take-home message from this talk. If we try and think, okay, so how many patients are receiving the care that they need, the critically ill patients, and therefore what is the unmet need in Malawi? We looked at this with over 1,000 patients. And this was just looking at patients across the board in all hospital wards. And of these patients, we found that 45 were at that point in time hypoxic. And of those 45, only 5 were receiving oxygen. So there was at that point an unmet need for hypoxia treatment of almost 90%. And similar findings were found with hypertension, where there was an unmet need of slightly over 90%, and unconsciousness, where we thought that unconscious patients should have some sort of airway protection, even if it means just lying them in the lateral position, in the recovery position. And 53% had an unmet need of that care. Tachypnea as well, so fast respiration, none of those patients were receiving oxygen. So this slide is saying that there's this was pre-COVID, I should say, was a very, very large unmet need for this sort of basic critical care. Just to mention, and I think Rupert made the same point, that there are such different levels of resources for caring for patients with critical care. So the care is not the same as ICU care, and this is not limited to just different countries with different resource settings. It's also within countries. For example, university hospitals often have more resources than regional, which have more resources than district hospitals. And also within the same hospital, you have different resources in the daytime than you do in the nighttime. So if we want to improve the outcomes of critically ill patients, we need to think of what care are these patients getting in the middle of the night in district hospitals. And what we've seen in our research is this is key even in high-income country settings, so that the care of critical illness can often have deficiencies in night times in district hospitals and so on. So this led to the development of a concept to try and come up with what is the care that all patients with critical illness should be receiving all the time in all hospitals in every country of the world. So a basic care kind of concept, the minimum standards, that if we could define this, we could then study how much are patients receiving this and what would be the impact of increasing this care. So this concept has been called essential emergency and critical care. And we included both terms, emergency care and critical care, because of the desire to have a patient-centered focus. We want to think of patients with critical illness, and these patients, when they arrive at the hospital, are often seen by the system as receiving emergency care rather than critical care, whereas when they're on the wards, they're seen as receiving critical care. But from the patient's perspective, it makes no difference, but it makes a difference for how the hospitals and how the clinicians are seeing it. So it's the same care in the emergency departments and within the hospitals. We have a kind of model guiding this, thinking that the care for these patients can be seen to increase in complexity and then have different names for those different levels of complexity, so that the essential care is this lowest level of complexity. And it can be in the emergency unit, it can be in the operating theatre, ICU, ward, the very basic care, which kind of forms then the fundament, the basic level for this care. If there's more resources available, then you can take a step up and provide the additional intermediate care or up to the advanced care, which is usually then just in the ICUs and maybe in the operating theatres. So just to be clear that we're talking about this bottom level of care, this essential emergency and critical care. One version of this, we introduced this protocol into a hospital in Tanzania called the Vital Signs Directed Therapy Protocol. So this was a protocol for task sharing between the doctors and nurses, where the nurses would check the vital signs, look at this protocol for whether the vital signs were normal in green or abnormal in yellow or dangerously abnormal in red. And then it guided actions that were then allowed to be done by the nurse without having to wait for the doctor's prescription. So such as lying the patient on the side, increasing the oxygen, giving a fluid bolus. And what we saw when this protocol was introduced was the acute treatment when a danger sign was identified increased on this ICU where it was introduced, and mortality for the patients with low blood pressure actually fell. So this is a sort of basic essential emergency and critical care that we're talking about. A framework to help us think about how this care is provided and where we could have areas to target for improvement is this conceptual framework. If we start over in the top right in that red box, what we're all wanting is survival of the critically ill. And we think in order to get there, these critically ill patients need to have their vital physiological functions stabilized. To get there, EECC is required. So this essential care needs to be given in an effective way to all of the patients. So this is our goal, to increase the effective coverage of this care. And this care consists of two domains. We need to identify the critically ill patients, which is often a big problem in hospitals. We don't know which ones are the critically ill, and then we need to provide the essential care. And in order to do these two things, the hospitals must be ready. This is the structures in the Don Obedian framework that Bruce talked about at the beginning of this session today. So the hospitals need to have equipment, drugs, human resources, everything in place to be able to provide this care. And then the processes are then needed. So the clinical practice needs to be good, both for the identification and the care. So an example on the left would be for a hypoxia, hospital readiness would be the existence of a pulse oximeter and staff able to use it. Clinical practice would then be the use of the pulse oximeter and the identification of the hypoxic patient. So this framework, I think, can be useful for both research, for assessment of current quality of care, and for other things within this field. We then moved on and thought, okay, so we have our concept, we have a framework. What's in this? What is the content of essential emergency and critical care? And we didn't want to define this as a group of researchers. We wanted to get consensus across the world from global clinicians. And crucially from a very varied group of global clinicians, given that this concept applies to all patients in all specialties. And we needed then the content in these two domains of identification and care and relevant for both these clinical processes and for the hospital readiness. So we conducted a Delphi consensus, which is a method for reaching consensus among experts, and involved with 269 people from many settings across the world, spread among low-income countries where the majority were working, middle-income and high-income countries, and expertise from emergency care, intensive care, and also from ward-based care, medicine, surgery, pediatrics, obstetrics. And we won't go through in detail, but what it came up with this process, which you can see in the publication, is 40 clinical processes that are seen to be the first line, the basic, the most essential care for critically ill patients. So this includes things like identification, that using triage, using the normal vital signs that we all know well, and also treatments such as oxygen, insertion of nasal pharyngeal airway, and the like. But it doesn't include more complex care such as blood transfusions, non-invasive ventilation, or dialysis. So it has a kind of ceiling on it. And then we also specified what hospitals would need to have, the requirements for hospitals to be ready for this, divided up into these different categories of equipment, consumables, human resources, and so on. So this is things such as pulse oximeters, IV giving sets, but not more advanced things that are not required to do those 40 clinical practices. And this work is done within a Wellcome Trust-funded project called Poetic, Provision of Essential Treatment in Critical Illness. And within that project, which is currently ongoing, we're investigating the optimal methods for providing quality care to critically ill patients. Projects based in Kenya and Tanzania, and includes many different methods, including policy analyses, surveys and questionnaires, work interviewing and discussing with frontline health workers and other stakeholders in those countries and globally, and also crucially some health economic work to try and understand the cost effectiveness of these different approaches. The full findings will be coming out in the next few months. Preliminarily, it can be said that we found that it's very common that district hospitals and referral hospitals are unable to provide oxygen at high flow rates. So that's the kind of setting where we're in at the moment. And only 17% had one or more ICU or even a high dependency unit bed. The costs of providing EECC to a critically ill patient using Tanzanian costs are approximately $20 per day. Which compared to the costs of providing more advanced care, which are up to about $300 per day. And if we're working in areas where oxygen is a limited resource, then providing oxygen to patients just using simple oxygen therapy techniques can be, the same amount of oxygen can be provided to 6 patients for every 1 who is receiving mechanical ventilation. But there's a lot more findings coming out from this project over the next few months. So what are the next steps? How to implement EECC? So just some kind of guidance of what could be done. So I think it would be an ideal thing for hospitals to start doing assessments of where they are in terms of EECC, identifying them where the bottlenecks for EECC are. Is it a lack of human resources, lack of drugs, or is it a lack of the routines, the processes for providing this care, leading to action plans for how this care can be improved. Thinking about how hospitals are organized, ensuring that severity of illness is a key principle for caring for patients. Often the diagnosis takes precedent, but I think thinking of severity using triage at arrival to hospital, but also regular assessments on the wards is really ideal. Thinking of the infrastructure, the setup for the hospitals, whether they should have an emergency room at the arrival to the hospital, or triage desk, resuscitation room, these sorts of things. Also post-operative recovery rooms, or high dependency units. Where should the really sick patients be looked after? Should we be concentrating the care and the resources for them in certain physical locations? And ensuring that these emergency drugs, supplies are always available. And one way to do that is to have an emergency trolley or a box, which is always kept restocked in every ward where critically ill patients can be found. And then definitely a big focus on health workers, making sure we have enough health workers with the requisite skills to be able to provide this basic care. And that probably includes both pre-service training and then regular repeated training for in service. And then policy engagement. So make sure that we have, and within the Poetic project, we are doing this, direct feedback to national policymakers. And we've been doing that through the COVID pandemic and also reaching out globally to WHO and other stakeholders. One thing we have, and I think this could be connected very nicely to the perioperative network and to APORG and these other networks we've discussed today, is we've set up a network of clinicians and researchers interested in EECC. So the EECCnetwork.org, please go in and have a look at that. And if you're interested, you're very welcome to join. And we should think of ways of getting all these networks together, I think. Last slide, future aims. We want to continue to improve the understanding of the global burden of critical illness, get some better numbers there, conduct these bottleneck analyses and understand what's meaning that, what's underlying problems for the world to be able to do better EECC, and then lead to intervention studies, maybe cluster randomized trials, for example, looking at the patient outcomes, but also lots of process analyses and understanding what happens to the system when these trials take place. I think a good way of framing it at the moment is about pandemic preparedness. So I'd say COVID has really shown to us that if the system is not ready to provide EECC, then when a pandemic hits, we cannot look after our patients. And the terrible scenes from India last year when patients were not receiving this care is testament to that. And we want to look at how to implement and lead to policy change. Potential impact, if we really would succeed in getting EECC to everybody, with very rough back of an envelope estimates, we think we could save 500,000 lives globally every year. And the take-home messages are that critical illness is common, there's a large unmet need. If we want to provide care to these patients, then we should be prioritizing this essential care rather than the high-tech care. And if we do this, there really is a large potential for averting deaths. And I've just got a series of resources there that I can send slides to anyone who'd like, and you can see all these different resources. Thank you very much.
Thank you, Dr. Tim, for another exciting presentation. So we have another 10 minutes for questions, opinions. The floor is open for questions. Let's take 10 minutes for discussion, then we will break for lunch. Munir, you're raising hand. Maybe you can unmute yourself and proceed. From
No, I was just appreciating the quality of presentations and saying thank you. I have no question.
Okay, thank you.
Video logo kan şaşırıyor karası.
Okay, Professor Bruce, I can see your hands. Proceed.
Thanks. Thanks very much, Tim. I think Tim's talk illustrates, if we go back to the whole non-obedient concept for quality of care, that in the environments we work as clinicians, the processes which are in place improve the quality of care. And so the EECC work shows it quite clearly. It's about trying to implement processes to make care better. And similarly, the work in ASOS2 showed it was probably our lack of ability to implement processes which contributed to us not being able to improve the quality of postoperative surgical outcomes. So as clinicians, if broadly speaking, we need to be working on implementation of processes which ensure safe acute care. And as governments and hospital administrators and that need to be working on resources to ensure that what we do is enabled. So processes will only get us to a certain point, and the ceiling will be the resources that are available to the clinicians. So I see this, if we want to improve quality of care in our environment, which say in a low resource environment, as clinicians, we need to focus on processes and we need to advocate for resources. And as administrators and leaders, they have to spend the time looking towards enabling resource generation.
Thank you for the. So if there is no question, may